Okay, so welcome everybody. Here we are. I want to say early August, but not so early August. We are well into August. So glad to be back with you tonight. Thank you to everybody in our audience for being here, and thank you to those who are watching via YouTube. I want to introduce our esteemed host, Glenn Grossman. He's an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years, and he taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, the Military Health Service, the CDC, and other programs within the United States and abroad. All views expressed today are his own. All right, Glenn, as usual, please update us. How are things going here in the United States? Talk to us about these variants of concern, vaccination in particular. Tell us about what is going on with Delta.
Thanks, Rebecca. Thanks, everyone, for joining. All right, so here's my screen. Unfortunately, we're in yet another surge. And unfortunately, yet again, when we look at the country, here's the current level of transmission. Everything's either orange or red within the United States, among the 50 states. I do believe this is probably going to be our last surge. Right now, let me just jump to this slide real quickly. The big question is what percentage of the population is still at risk? I think a really good estimate is that around 40% of people in the United States have been infected so far. And then we have the vaccination rates here, which are a little bit hard to see. I'll just make them bigger for a second. And so basically what we're looking at here, is that among people over the age of 65, over 90% have gotten at least one dose. So that's good. 80% are fully vaccinated. It goes down a lot as the denominator gets bigger and there's people age 12 and over. It's roughly 58% have been fully vaccinated. And among the entire population, including kids, over 50%, slightly over 50% have now been fully vaccinated, and closer to 59% have had at least one dose. But as we know, a lot of kids who are under the age of 12 are not yet eligible for the vaccines. They probably will be within the next 5 to 6 weeks. We expect that within the next 3 or 4 weeks, we should have some early readouts of the results for the kids of the underage for, I guess, age 5 to 12. And so we're waiting to hear back for once that reads out, then it'll probably take another few weeks for the FDA to grant the approval. And so that's what we're waiting for. But anyway, when you put these two numbers together here, comparing both the vaccinations and if we assume that on average, there's an equal distribution of infection rate previously infected, which we can't necessarily assume, but for a crude estimate, I'm going to apply it, then that means that among people over the age of 65, only 5.5%, 5.7% have no immunoprotection at all. Among people over the age of 18, it's 17.4%. Over age 12, it's 18.8%. And for the population as a whole, it's 25% essentially. But what this means is that the higher the risk of people, there's less and less host bodies available for the surges to continue. And so what we'll see happen with this surge, let me go back here for a second. In fact, let me go to this one. So what we're looking at here with the surge, we've had the first surge. Remember, this data wasn't very good. The testing was very poor at the very beginning, March, April of 2020. So don't pay too much attention to the actual cases here, but that was that first surge and the lockdown. The second surge was the summer surge. And so that's this one here. The third surge was quite big, and that was this past winter season. Then we had this little, relatively little surge compared to the winter surge that was in the late spring. And now we're having this one. And this one, and when you compare this summer to last summer, you can see that there's no comparison. The Delta variant is just crazy out of control. The percent positive, which is the yellow, not percent positive, the percentage of emergency department visits that are related to COVID is rising rapidly and is on pace to hit or exceed the percentage of emergency department visits that were due to COVID back in January at our peak of COVID-19. So although I don't have the numbers here for March and April of the previous year, they were quite high then as well. But so anyway, this is where we are here. What I was saying though, in terms of this surge, is that either we have heavy constraints on this and then we drop the surge down and it sort of slows down a little bit and then comes back in the fall and winter, or the surge just continues through the fall and winter. But I think that the case that we're looking at, this is probably going to be the last one. The Delta variant is far more contagious than any other variant that we've seen. It's around 50% more contagious than the Alpha variant, which was this surge that we had in the spring. And it's around 2 to 3 times as contagious as the variants that we had this past winter. And so because of that, the good news for that, I mean, the bad news is that we have this map. And the bad news is that pretty much everyone is going to get exposed or infected to the Delta variant within the next 3 to 12 months. There's no way to escape it at this point. It's just so much is out there. But that's the bad news, so everyone needs to get vaccinated as soon as we can. The good news for this, though, that a lot of people are not talking about, but I maintain is good news, is the Delta variant. Whoops, my computer. The Delta variant, which is the orange, so it includes the B1617.2, AY3, AY2, and AY1, like all this, is wiping out all of the other variants in the country. So you might have heard of all of these other scary variants that come up in the news every once in a while, Gamma and Lambda and Epsilon and all these others. They are being wiped out of our country. And that's because Delta is so contagious, it's rushing through the population, and there are simply not enough host bodies left for these other variants to infect people. And so for instance, P1 was this yellow one that you see down here. That was, I think, the Brazil variant. And that one is now diminishing very rapidly. It's going away. So that's really good news. When you look at this on the global level, the two that people have been looking at still, or that in terms of concern, I think are the Lambda and the Gamma are the top 2 contenders. The Gamma has been very common in Brazil, and Lambda has been very common in Peru, Chile, a little bit in Germany, and a little bit in the United States, very little. But when you look at this, so if you go back some months, you can see that, like, so here's Peru. Peru back in, let me make this a little bit, back in January, around a quarter, so 27% of the cases that were screened were Lambda. Then it slowly, progressively, so again, we're looking at Peru, it jumped from 40% to 64%, jumped to 82%, now Peru 91%. You can see that it was very contagious in Peru. So there was a concern that maybe this would be something we need to worry about. So this was May, it reached 96%, 97% May. But then you see in Peru something interesting. It starts to go down. And why is it going down? Because Gamma is coming. So now maybe Gamma is more scary than Lambda because Gamma is out competing Lambda. So here's Peru. So in Gamma jumped from 5.6% here, and Lambda was at 92, and now the Gamma dropped to 16, or increased to 16%, and Lambda dropped to 81. So Gamma is out competing Lambda. We don't have any more for Peru. They weren't talking about it. But similarly, let's look at Chile. So here's Chile. You had 38% Gamma and 40% Lambda in April. But over time, look at Lambda is going down, 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 29%, 25%, 24%, 18%. Now it's at like 20%. And Gamma was better, or more contagious, not better, was more contagious. If you're looking at this as like a horse race, it had more fitness, we would say, in terms of evolution. It was more contagious and was better at spreading. But when you look at Gamma compared to Delta, which is this aqua color, the Delta everywhere in the world is taking over Gamma. So for instance, when you look at Brazil, Brazil had a lot of gamma, 77%. In fact, that's probably the reason, even though it was right near Peru and Chile, probably one of the reasons that Lambda didn't really get a foothold in Brazil is because there was so much gamma. And so just gamma just kept it all out. But then when Delta started coming around, then we have a little bit of data. You can see that Delta, that in Brazil, it was up to 95% was gamma. Then Delta started hitting. Here's Delta at 2%. And then over time, it's jumping. Now it's at 20% in Brazil. So clearly, the Delta variant is more effective. It has higher fitness, more contagious than the Gamma variant. And so that means that over time, Delta globally, in fact, we have a map that we can look at Delta globally. It's not a great map. There's not a lot of sequence covering, but what we'll find is that Delta is so powerful, it's wiping out all of the other variants that we see. Any country where we look at a head-to-head race of any variant there versus Delta, Delta is winning universally so far. And so what that means is that in order for another variant to be even more to spread more than Delta, it has to be more contagious. It has to be able to infect people even more than Delta already is. And it's just very hard for a variant to achieve that, because some people are talking about this idea of peak fitness, that at some point you get to this idea where it is so contagious that it just doesn't really have any opportunity to get even more contagious than that. And so a lot of people think we're at around that point with Delta. And so remember, I've said this before, the original Wuhan variant is now extinct in the world. So the original variant that was first found in Wuhan was not as effective at reproducing. And so other variants arose, and those variants became so contagious that the original Wuhan variant ran out of hosts. And because it couldn't reproduce anymore, it died off. And so there is no more Wuhan variant in the wilds in nature. All of the descendants are now out there. And so Delta has a really good chance of wiping out all the other variants. So I've talked enough about that, but I see this as good news. And that's why I have confidence that by March, I think that we're going to be pretty much near the end of this. A lot of it's going to depend on how many kids get infected over the next 3 to 6 months or vaccinated in terms of the protection. And that's going to be a big question. I don't know what that's going to look like. But the thing is, so among kids, and we'll talk about that a little bit later. I know some questions have come in. The severity of the disease is orders of magnitude less than for adults. So even if kids are infected, it's not nearly as scary. It's still scary. It's not the safest thing. So for instance, kids as a cause of death over the last year, this COVID-19 was one of the top 10 causes of death for kids in the United States. So it's not like it's nothing. But the thing is that kids just don't die very often. Most people have a life expectancy of many, many decades. And so as a result, the risk for kids is very, very low. Not completely out of the woods, but it's somewhat low. And so this is something we're going to be talking about more. Let me just see right now in terms of the cases, you can see despite the transmission rate, you can see that the cases are still actually located a lot in the South. We still do have this regional variation. When you look at the United States, you see this continuing regional variation. So the blue is the South, and that's where a lot of it's going on right now. But in every region, we're seeing growth. So in the West, we're seeing growth, and green is the Midwest, and red is the Northeast. We're seeing growth everywhere. Louisiana, you see, it's almost like a straight up line in terms of the growth rate that we're seeing in Louisiana right now, with a little bit of I'm not sure what's going on at the top here, but it's just continuing. It's going to be very difficult for people to avoid the Delta variant at this point. If people are not vaccinated, they're going to get infected within the next 3 months to 12 months, and there's no way to avoid that now. And then here, the key thing now is, well, why don't we let it happen? If people made a choice not to get vaccinated, why don't we just let them get infected if that's the choice that they want? And the main reason here are two main reasons. First, what we're looking at here is a map of hospitalizations around the country. And you see that there are a bunch of counties where the hospitalization rate is extremely high. And the problem is there are hospitals now around the country that have already met their maximum limit now of beds that are filled now because of COVID. And this was the whole huge reason that we shut down in March and April of 2020, was to avoid running out of beds. And it's happened again. We have now run out of beds in some places. And you can see that the red counties are just increasing. I've been following this, and they're increasing and getting redder in different places. And so even though it's a regional thing, so we don't need to shut down everywhere, the problem is once you run out of beds, then people who go into the hospital for other things than COVID, so say they get into a car accident, or they have a heart attack, or they have any number of things that would have just put them in the hospital without COVID, if there's no more beds, then what do? You're going to have much higher death rates and morbidity rates just because there's no more beds to treat people. So this is a serious crisis in large parts of the country. The problem is that the state and local governments are responsible for addressing these things, and a lot of the state and local governments just are laissez-faire at this point. And so it's going to be a little bit worrisome to see what happens over the next 3 to 6 months. The other thing is, when you look here, when you look at, oh, I wanted to go to this one. When you look at the age, this is one thing that some people are not talking about. When you look at the age distribution, so this is again the surges looking by age. If you recall the first surge back in March and April and May, we weren't testing very well. So we prioritized testing in people who were hospitalized. So it makes sense that the purple, the oldest people, were the ones who were the most highly tested. But then what we found was this interesting thing where this last summer and early fall, it was really the 18 to 29-year-olds, and then to the 30 to 39-year-olds and 40 to 49-year-olds. But primarily you see this dotted aqua line, which is the 18 to 29-year-olds, that were really driving a lot of the epidemic there in the United States. They were the ones who sort of launched that surge in the summer by attending the bars and not really following precautions. And then they sort of just kept up the act behavior that kept up the surge, and they sort of led to the next surge coming. What we're finding is a similar pattern now where you have a lot more infections, again, in the 18 to 29-year-olds and 30 to 39-year-olds. And so we're not seeing as many hospitalizations yet as we saw, or deaths as we saw in the fall and winter. But I think that that's largely due to two reasons. First, you've heard about the vaccinations. That's having a massive impact, and it's real. But the other reason, I think, is still this latent idea that a lot of younger people are the ones who are getting infected. And so, of course, the hospitalization rate and death rate should be expected to be lower because you don't have as many older people getting infected. The big question is going to be in the fall. So September, October, do we see an increase in older people getting infected and hospitalized? And I think that the vaccinations are so good, we're probably not going to have to worry about that. The booster shots, the question about that is we're probably going to know more within the next month, probably within the next couple of weeks. But I think that there's a high demand for a booster shot, particularly among people who are older or more vulnerable. And just because people are really motivated to get a second shot, I think that they're probably going to be opened up for at least a subset of the population. A lot of other countries have already opened up booster shots, so a third shot, including Israel, including United Kingdom, including some others that I don't have the full list in front of me. So it would not surprise me at all if we see that. And I think the booster shot would make a big difference, particularly among the elderly and some people with comorbid diseases like immunocompromised people and such, because typically vaccines in general just don't last as long for them. So it would make sense to give booster shots for that subset of the population.
Glenn, I'm just gonna jump in there if you don't mind,
Sure.
to talk about how the vaccines are holding up against Delta. So it sounds like this Delta Lambda Gamma horrible fraternity party. We really just have to keep an eye on Delta. So lots of folks are asking, okay, so let's talk about Delta. How are the vaccines holding up? With or without the booster at this moment, how are they holding up?
Yeah, so that's an interesting question. Let me jump to the answer if I can find it quickly. All right, so the two basic sources of data right now on this question are coming from UK and from Israel. The United Kingdom, I've shown some of that data previously. Here, I'll show it again real quickly. It suggested that there was around an 80% vaccine effectiveness against symptomatic disease, and that there was a 96% effectiveness at keeping people out of the hospital. The 96% effectiveness at keeping people out of the hospital, it stayed around there. It's dropping a little bit, but it's roughly that number that we're looking at still. However, back here, it's now appearing to drop from around what I just showed you. Now it looks like UK, according to the most recent UK data over the last week or two, that it protects from infection by around 50%, so 49% from Delta. So Delta is able to get through the barrier, but it does cause infection, but virtually all of the infection it causes is either asymptomatic or minor symptoms, not severe symptoms, and definitely not hospitalizations. So it's definitely holding up extremely well. The whole point of the vaccines originally were to prevent hospitalizations, death, and severe symptoms. The issue now is, this is the major reason. We'll talk about this in a little later tonight. But the major reason that the CDC has now changed its mask guidance so that people who are vaccinated should wear masks is primarily because now a lot of the vaccinated folks are becoming silent but deadly transmitters. So they're becoming asymptomatically infected, maybe minor cold-like symptoms, but they can breathe out as much virus as people who have never been vaccinated and potentially infect people around them and put the unvaccinated at risk. And again, the major reason we care about people, a lot of people who are unvaccinated who are making a choice. Every medical health professional understands there's no controversy that they're making a poor choice, the way people make poor choices all the time. They choose to smoke and do other bad habits. But the problem is, just because someone makes a bad choice doesn't mean that they deserve to be hospitalized or die. And so we still need to protect people. And so that's one of the major reasons that we are masking up for vaccines. The other thing is that, recall, vaccines still do prevent getting infected. And so even if you're vaccinated, wearing that mask will help to prevent you from being infected. And so even if there's a much smaller risk of being hospitalized or having some of these other severe symptoms, the vaccines will still help prevent that even further. So two other things to answer your question. Just sorry for interrupting for 1 second. So Israel, and so this is really interesting. Israel showed efficacy. First, they showed efficacy that it was 64% effective at preventing infection. Forget about severe symptoms for a second, just infection. Now their most recent study, and it's smaller, so the UK had better data, but now they're suggesting it's only 40%, 39% effective at preventing infection. And one of the major reasons for this is that in Israel, they had 3 weeks in between the first dose and the second dose. And that's similar to what we had in the United States. We had three-week separation for some of the mRNA doses and 4 weeks for some of the others. But in UK, they wanted to give a first dose to as many people as they could. So there was a little bit of protection. And they didn't give the second dose until 12 weeks after the first dose. And we know that the longer the delay between the first dose and the second dose, the more effective it is in terms of stimulating the immune system. And so that might explain why we are seeing better data in UK, but we don't know yet. But the key takeaway here is that we have a dramatic reduction in hospitalizations and death. And so that's the major issue here. We're seeing in the UK I think this is the UK, an 8-fold reduction in disease incidence, a 25-fold reduction in hospitalization, and a 25-fold reduction in death. The one other thing I want to point out is that with vaccines, we were very lucky with the mRNA vaccines that it produced a huge amount of antibodies that were somewhat neutralizing. And so it protected even simply getting infected. That's not the way most vaccines work. Most vaccines work where you get infected at some later point, but because you have a prior memory that you've gotten from the vaccine, then you have antibodies and an immune response that's generated much more rapidly. And in fact, Singapore just published a study, and what they showed is the green line versus the red line. Red line are unvaccinated people, green line are vaccinated. And what they found was that people who are vaccinated at the beginning had the same amount of virus that they produced. Yet, within the first 6 days, their immune system kicked in. And so very, very rapidly, their virus levels dropped dramatically. Whereas the people who are unvaccinated, their viral load stayed higher for much longer. And so this is the way vaccines are supposed to work, and our vaccines are working exactly as we had originally intended. We sort of got way better results than we had thought we could, and so we got sort of lazy because of that. But right now, in terms of the way vaccines are supposed to work, we're seeing that they're working exactly as we see. There's always a primary antibody response, which is the first response, and then the antibody levels drop in the body, but the memory remains. And then when you're reinfected, there's a secondary antibody response, and then that happens over a period of days. And so that's what we're seeing here.
Glenn, you've showed us many graphs over our time together, and I cannot think of one that is more compelling than this Singapore study in showing how the body reacts and how the vaccines are so critical. This is really, really wow.
Thanks. Well, again, I get credit. I didn't write the study. The people who wrote the study made the graph, and I thought it was great, and it would be useful for people to see. A great visual, so I took it out.
Well, that's what you do. There's a crazy amount of data out there, and you distill it down to its essence for us. And that right there, I can't think of a word other than wow. Okay, I'm going to press pause for one moment because we have some questions from the audience. Rachel, if you could unmute, please, to ask your question, that would be great. Thanks.
Sure. So I guess I'm curious mostly about, with these studies, is there a distinction that they're making between the mRNA vaccines and the non-mRNA vaccines and their efficacies? Like the UK, they primarily gave AstraZeneca, and the effectiveness, although now after you showed the second part in Israel, I guess my question is a little moot, but I was wondering if the non-mRNA vaccines, the J&J and AstraZeneca, are as compelling, what that's going to mean for the booster shots, how are they going to recommend mixing an mRNA and an mRNA? Give us a little more insight into the difference.
Yeah, that's a great question. So unfortunately, there's two unfortunate things. So here's a summary of how effective the vaccines are likely to be. So Moderna, you see, we don't have B1617.2, which is the Delta variant. The B1617 is sort of includes Delta, but also includes other things. And you see that that's still, our understanding is changing a little bit. So we can't pay too close attention to what this is saying. But just as a reference point, when you compare Moderna, where it says here it's 83%, versus the Johnson & Johnson with the Janssen 64%. So it does drop a little bit in terms of efficacy of preventing disease. This is the most important thing, the disease. Again, the infection, we know the infections are happening, but really what we care most about is keeping people out of the hospital, keeping people alive. And so AstraZeneca, same thing, it's around 53%. So it's not quite as effective. There have been a bunch of studies now looking at crossing over. So doing the first shot of Johnson & Johnson or the first shot of AstraZeneca and then the second shot of mRNA, even though that strategy is not approved by the FDA, it has been demonstrated to be safe and effective based on the studies. And so it is something that we have seen in other countries that they're starting to adopt that and allow people to do. And so right now it's not something that the FDA or CDC is promoting, but it's I've definitely heard in other countries that's a thing, and it's a reasonable thing to do. In terms of a booster shot, it might be something that they recommend. The other thing is that because so we have so much data on the mRNA vaccines simply because they've been, let me see if I can pull this up. Vaccine type. No, I thought that there was, oh, vaccine by dose? No. Anyway, I thought that there was something that I'd seen comparing the Pfizer versus Moderna versus Johnson and Johnson in the United States and abroad, looking at the different proportions. The problem was when we had that pause for Johnson and Johnson in the United States, it scared a lot of people. And so we never really got the amount of people after that pause getting the Johnson and Johnson vaccine. Everyone really just went to the mRNA vaccines after that, with some exceptions. But because of that, we just don't have the amount of data out there because there's so few people that have taken it. I mean, there's a lot, but relative to the size of the number of people that have taken the mRNA vaccines, we have just a ton. We have tens of millions of people have taken the mRNA vaccines, and maybe order of magnitude a million or order that level of order of magnitude for Johnson and Johnson. So we can say things with a lot more confidence about the mRNA vaccine. But like I said, despite that, it's not that the Johnson and Johnson vaccines or AstraZeneca are not any good. They're still great, not quite as effective as mRNA. And probably if there's a booster shot coming, it wouldn't surprise me if there would be more eligibility for people who took those doses.
Thank you. We got a
Yep.
number of questions from folks in the audience on this chart and understanding the booster shot. So that's really helpful. So we will stay tuned for more on that. It sounds like more to come. Okay, let's talk about kids. Let's talk about school. Let's talk about the different mask mandates. But before we get to that, can you tell us about Provincetown and the outbreak and the CDC changing their guidance on masks based on that singular case study? What have we learned and how is that impacting kids going back to school?
Yeah, absolutely. And in fact, well, one thing before I go on that I forgot to show, but it's a really great, just to punctuate the discussion we just had. When you look at the share of hospitalizations for COVID who are among vaccinated versus unvaccinated, on average, look at these numbers across the states. You see that very, very few people who are vaccinated are actually being hospitalized now. So the vaccines are dramatically working against hospitalizations. You see 95%, in some places 99% are in New Jersey, 99.9% of people that hospitalized for COVID are unvaccinated right now. So when you're talking about, and let me just go back for 1 second just to punctuate this, in the United States, when you're talking about New Jersey, vaccinations, whoops. So when you're talking about New Jersey, people, percentage of the population, let's say at least one dose. So New Jersey has 67% of the people have received at least one dose of the vaccine. And yet, despite that, only 0.1% of those people are hospitalized, whereas 99.9% of the remaining small number of people who have been unvaccinated are the ones who are hospitalized. So the vaccines are amazing. This is where it counts, folks. Remember, if you get infected at this point and you're vaccinated and you get a cold, it's just a cold. I mean, that might be something we talk about a little later too. I have some graphs about that, but it's just, don't be worried about a cold. So, all right, let's jump back to the Provincetown issue. All right, so Provincetown. So Provincetown, big gay area where they had a lot of events over the summer. They had some events in July where there were a lot of people who were vaccinated. I think, in fact, they required mandatory vaccinations for some of these events. And so people went in and they were very crowded bars and a lot of people got infected and spread the infection. And so what was interesting about this is normally for looking at outbreaks like this, it would take a long time to track people down. And the public health organizations that are responsible for it typically only focus within their own state, say Massachusetts or Connecticut. And with Provincetown, it's a resort area, so people come from all different states there and then go back to their hometowns. So normally it would be hard to trace, but the gay community there really came together and worked closely with the CDC to identify all the people who had attended these events and all people who were staying over at the houses, their contact information, anyone who could have come into contact. And because of that, the CDC was able to generate this very rapid report in the Morbidity and Mortality Weekly report. And so this was great. From this, there were a few things that they found, but the major finding was this thing right here, this one chart. And what this shows is the viral load in unvaccinated people who got infected was essentially the same as the viral load in vaccinated people who got infected. And so because of this, it's assumed that people who are vaccinated and infected are as contagious as people who are unvaccinated and infected. And so that's what led to the whole mask mandate changing. Well, it's not mandates because the CDC has no power to do mandates. All it can do is give guidance. But that's why the guidance changed again because of this. I'm not sure I fully agree with that interpretation. And the reason is twofold. One, so yes, this is true that the viral load might be higher. But again, we just saw the Singapore study up here, and we saw that the window of time that they're contagious might be lower. And so that's one thing. And then the second thing is that among the vaccinated, if they have some existing antibodies that are able to respond, even though they might be shedding virus, it doesn't necessarily mean that the virus is contagious that they're shedding. And so we know for a lot of people, after they get infected, they might shed virus and have positive test results, but they're no longer actually contagious. And so for me, I'm still not convinced that just because the viral load is higher, that means that they are as contagious as or just because the viral load is the same, let's say, between vaccinated and unvaccinated, that's not compelling enough to me that they're as contagious. The reason is that in previous studies, I think there's one in Scotland that I was looking at, doing contact tracing, they found that vaccinated people who got infected were only 50% as likely to be contagious as people who were unvaccinated. This was not the Delta variant, and it might not apply to Delta, but it's still, this is not the study that for the Provincetown study would not be the study that would be the most compelling for me right now. And so, but it's compelling enough that the viral load is so high, and it fully, I fully agree with the CDC changing its guidance just based on this one graph alone. But the jury's still out on the contagion component of this.
Interesting. Thank you, Glenn. So now that many areas have adopted mask wearing and many, not all, are requiring schools to mask students and teachers, can you tell us more about what you expect to see in schools this fall?
Yeah, absolutely. Let's talk about kids. There's a lot of things going on here. So I have a bunch of slides I put together, just a summary of where we are. So I'll just run through them pretty quickly. All right, so first, what we're looking at here is the risk of having a fatal case of COVID-19. And remember, there's all these other things we need to worry about, not just death with COVID. I mean, you don't want long COVID, you don't want to have scarring of the lungs. There's all sorts of things that we worry about. But just as one metric that we can follow with a good data is just looking at the risk of death. And so what we found is that for 90-year-olds who get the vaccine, it reduces their risk down to as if they were essentially, what is this here, maybe a 60-year-old or 55-year-old. Among 80-year-olds who get infected, it reduces their risk to as if they're a 50-year-old unvaccinated person. So when you're starting to go down into age, this is a logarithmic scale. And so you see that the risk drops dramatically. It's not just a linear slope. What we're seeing here is it drops from 1% to 0.1% to 0.01%. If you follow this line down, it's hard to extrapolate sometimes because you don't know if the curve changes a little bit. But if we just extrapolate this line down, then for a 15-year-old, you would expect that their risk of a fatal event would be less than 0.001%. After, oh no, not 001. This would be 000 with another zero in there. 0.01%. And so that is enormously small, or the opposite of enormous. This is extremely small. It was very small before the vaccines, and it's even an order of magnitude smaller after the vaccines. So every kid age 12 to 15 should definitely get vaccinated unless they have a very specific, this only applies to a very, very tiny fraction if they have a very specific contraindication that their doctor would know about. But otherwise, every 12-year-old to 15-year-old should be getting the vaccine. Despite the small risk, this is death we're looking at again. The risk of these other things still exists, and I'll go through that in a little while. All right, here's what we're looking at here. Let me make this one bigger. All right, so what we're looking at here are the hospitalization rates of kids under 18. And what you see is during the different surges over the course of the last year, in the fall and winter, there were a certain number of kids under 18 who were hospitalized. And now in this summer surge, we have hit that rate of hospitalized, of what were hospitalized. And you see it's going straight up. So there's going to be a lot more kids that are hospitalized. However, we need to interpret this relative to the magnitude of the risk. Because when you look at these other age groups, and let me make this bigger. So this gold color were the under 18 folks. You see that even though when you compare just the kids to each other, there were some changes over time that we just saw. But when you compare it to all the other age groups, you see that the risk of hospitalization is orders of magnitude lower. So it's really, really not nearly as risky for kids to be hospitalized. For the interesting thing is when you compare unvaccinated. So a lot of, I pulled some of these others out. Let me make some of these bigger for a second. So what we're looking at here are 40 to 49-year-olds. And so right now, their risk of hospitalization is about at the peak of where we were back in December, January from that last surge, and it's still rising. Whereas when you look at, who are these people? When you look at 70-plus-year-olds, their risk is only a fraction of what we were last winter because of the vaccines. So there are still some hospitalizations that are happening, but it's dramatically lower than what we had versus last fall and winter. So you see the vaccines are dramatically helping. There is still some risk. The key takeaway here is the kids, even though there's risk, the kids are not nearly at risk as hospitalization as older people are. The next slide here is, I showed you this a little bit earlier. This is just the cases by age. And so you see that the cases have risen. Down in fall and winter, the gold ones, the 0 to 4, 5 to 11, and 12 to 15-year-olds were among the least infected. And that was largely because of all the great work among people who went back to school to keep people safe in the classroom and whatnot. Whereas now you see that the kids are actually getting infected at a higher rate than the 65 to 70-year-olds and the 75 and older. And that's again largely because of the vaccines. A couple of other things. All right, so here's some numbers just to throw out there so people know what we're talking about. Since this time last year, more than 45,000 children have been hospitalized with COVID-19. So that's quite a lot. Roughly 400 children ages 0 to 18 have died from COVID-19 before the Delta variant. So we don't know what it's going to be like after the Delta variant. There's this open question that no one has the answer to yet, and that is the Delta variant more severe for kids than the other variants were? And the reason we don't know is because it could be that there's more cases now and more hospitalizations, but it's just because the virus is more contagious. So as if you're rolling the dice more. It's not that the dice changed and they're now making people more severely sick. It could be that it's the same old dice. We're just rolling them more because more people are getting sick. And so we're seeing a lot of hospitalization just because they're getting more people are getting infected. Alternatively, we do know that the virus is around 1,000 times more, the viral load is around 1,000 times higher than the previous variants back in December, January. And so once you have viral load that is so high, it makes sense that it could be the case that you would have more severe symptoms because your immune system has to respond much more heavily in terms of responding to all of that virus. So it could be, the jury's still out now. We don't know quite yet. The number of COVID deaths among children is more than twice the number of pediatric flu deaths reported for the 2019-2020 season. So order of magnitude, COVID-19 versus flu, in the previous variants, it was around twice as many children. Now with the Delta variant, you'd expect it would be more simply because more people are getting infected, but we don't know among the ones who are getting infected if it's more severe. That's where we are. A few other things to point out here. This graph here, among kids, so pediatric, this aqua color, among kids who are hospitalized, roughly half of them have no pre-existing medical condition. So some of them have obesity, other diseases that have been identified, asthma, whatnot, but almost half have no pre-existing medical condition. All right, there's a few other things here that are interesting that I was just going to go through, and I'll just go through them somewhat quickly. So I've mentioned some of this. One other thing that we didn't know is that, so previously with the previous variants, kids were very, very ineffective at transmitting it to other people. Generally, we identified adults as for every adult that was infected, the R naught, this R naught value, the reproductive value, that every adult on average would infect 2 to 3 other people. And that's just a very, very crude estimate. We know a lot of people infected no other people, and some people were super spreaders and infected a lot, but 2 to 3 on average. Whereas kids, particularly prepubescent kids, on average infect less than 1 other person. And so if it were just all kids, the epidemic would just go away because you wouldn't have an epidemic curve, it would just go away. With Delta, it could be that it's more contagious even in kids. Previously, under the old variants, it made sense for all the kids to go back to the schools. You would want them to still have masks, but it made sense if the symptoms were very, very mild generally if kids got infected, and so it was around twice as severe as the flu, and the risk of spreading to other kids was very, very weak, so that you're unlikely to spread it if you're under 15, let's say, or under 18. Then it made sense that all the kids should go back because there's really important reasons that kids should be in school. They don't learn as well typically when they're not in school together, and they miss out on all these other opportunities, learning opportunities and whatnot. So kids should be back in school. Now, my perception is it's an open question again, simply because the severity question is still an open question and the contagion question is still an open question. We don't know if kids with Delta will now be spreading it at a higher rate so that if one kid gets it, will the other kids in the class all get it within the next couple of weeks? And so that's this right now. I don't know that anyone has the answer to this yet. Currently, most thinking around the country is that kids should return to in-person learning. And we really should try as hard as we can to do that. And definitely, at least in the first few months of the school year, there should be universal masking and ventilation and everything we've previously been looking at. But I think there's still, with Delta, we don't know enough about contagion and we don't know enough about severity, that there's a lot of people looking at this question right now that are still looking at this. A couple of other things here. Let's see. So I'm going to skip over that. So that's skipping over that. There were a few things that I saw. I mentioned some of these already. So interestingly, over 4 million people, or rather over 4 million kids have been identified as being infected with COVID-19, or the virus that causes COVID-19. So a lot of people, but the CDC estimates that that's a underestimate because a lot of people just weren't tested. So they believe that the true estimate is closer to 27 million or more pediatric cases who have been infected already. The more kids that are infected, the sooner this is over for kids, because once they're infected, then they have some level of protective immunity, even without vaccination. The other things, there are like 1 or 2 other things that were popping out here. That's it for that. For the vaccines, some of the questions, I've answered a lot of these before. We expect, so among the 12 to 15-year-olds, we do expect within the next few weeks, I expect it to read out. For I think Pfizer was a little further ahead than Moderna. With 12 to 15, it's already approved. I'm talking about the under 12-year-olds. For the people, I know that the under 12-year-olds, I think the 5 to 12-year-olds, they just increased the number of people they were enrolling. And I suspect they were doing that just to be even more sure that if there was any signal that they might have seen, then they could say, no, it's not a real signal and that the vaccine is safe. So they're looking very carefully to make sure that if they release any vaccine to kids under 13, that it's going to be very safe. And that's the key thing to worry about. Anyway, those are the main things. There were a couple other things. I don't know if you can read the screen. It's kind of very small print, but if you want on the video, you can go back and pause it and you should be able to read those all right. There's a lot of interesting nuggets that an epidemiologist has put online that are really great. All right, Rebecca, back to you.
Very, very helpful, Glenn. Yes, lots of interesting nuggets. Much appreciated as always. Your slides are chock full with data. Question from Deborah. Deborah, if you could unmute to ask your question, just talking generally about breakthroughs.
Hi, Glenn.
Hey.
So the question for you is, how if everybody is being vaccinated, all these responsible adults are being vaccinated, how are there so many breakthroughs in completely vaccinated adults?
Yeah, so we think that a lot of the vaccinated adults are getting it from the unvaccinated. And that's a really interesting argument right now, because like in Provincetown, they weren't sure, but this question is, if vaccinated people can spread it as well as unvaccinated, then you'd expect the vaccinated people would just be passing it around to each other who are not wearing masks or whatever. If what we saw in UK and Israel, if the vaccines are only 50% protective against infection. And against the two numbers here are Israel is estimating that it protects around 40%, and UK's latest was around 50% from Delta. And so if it prevents 50%, then if someone is infected, on average, they can infect 2 to 3 other people, let's say, or now with Delta, it's maybe up to 10 other people. If you are vaccinated, it reduces your risk, but it doesn't eliminate it. So there's still a very high risk of getting infected if you don't wear a mask. But again, it still has huge protection from being hospitalized. So the key thing to worry about is we have to keep our eye on the prize. The key thing is it has a massive effect of preventing us from having severe disease. What it doesn't do is we still could have cold symptoms and still have get infected, be asymptomatic. We might be infected, not even know it. But it's just because the body, when the virus enters the body, it might infect some cells before the antibodies have a chance to attack it. And so by the time the virus starts to replicate in the body, there's already a lot of virus circulating around the body before the body has a chance to ramp up the immune system to attack it. And that's why people can still get infected, even though the immune response is sufficient to keep us safe.
Thank you, Glenn.
You're
Thank
welcome.
you, Deborah. Great question, Glenn. Thank you. All right, so we are nearing the top of the hour together. Why don't we wrap up with talking about any new treatments on the horizon for COVID-19 or those who are experiencing long haul COVID?
Yeah, there were 2 things here. Where I just had this. I think it was here. All right, so the World Health Organization, so there's a bunch of treatments still being investigated. They had 4 original drugs that they were looking at.
Glenn, excuse me for 1 second. Are you intending to share your slides?
I
or
am.
no?
I forgot to share it.
Okay.
Yes, so there you go. So originally, as you recall, there were 4 drugs that were being investigated for treating COVID-19. The first 4 were ivermectin, hydroxychloroquine, remdesivir. There was some HIV combination, interferon beta. None of these were shown to be effective. They all failed. And we know that now, even though there was controversy at the time because of politics, the science demonstrated they did not meet expectations, they couldn't be used. Some drugs could be used. So dexamethasone, for instance, is heavily used now. The monoclonal antibodies have been shown to be effective. Now, the World Health Organization is starting a new set of trials looking at the top 4 contenders now to treat these patients. And the 4 drugs that are being investigated now are a cancer drug called imatinib, an antibody named infliximab. It's used for rheumatoid arthritis and some other autoimmune diseases. Artesunate, which I'm not really, it's an antimalarial, so it's in there. I think that there was one more. Oh no, it's only 3 that are being investigated here. So these 3 are now the top contenders. The issue though is that Delta is moving so fast that by the time the trial is over, a lot of the world population is already going to have gotten sick from Delta. And so between vaccinations, a lot of the world is not vaccinated yet. And so we have to really do a much better job of vaccinating outside of the United States. But for the United States, like I'm saying, because so many people are either going to get vaccinated or infected within the next 3 to 6 months, by the time this trial is done, it's not going to make a huge difference anymore. For long COVID, these drugs are also being looked at in terms of the as one of the possible things to see if it has an effect. But what we're looking at here is where's my long COVID discussion? All right, so so this is a slightly similar discussion, but I wanted to just add it here. So in long COVID, the question was, among people who are vaccinated, does vaccination prevent long COVID? And unfortunately, we're finding that people who are vaccinated can still get long COVID. And that's another reason to wear a mask. And so what they've done, this study came out of Israel, I think. Yeah, this was in Israel that they were looking at this. And they tracked healthcare workers. And so healthcare workers tend to be younger than people because they're workers. They tend to be healthier than regular people because of something called the healthy worker effect and whatnot. And yet when you look at their results on follow-up, a third of people who were infected still had some residual symptoms after 2 weeks. 19% reported having long COVID symptoms after 6 weeks. So their symptoms persisted 6 weeks or longer. 9 workers are not, that's not the important thing. 23% took a leave of absence for work for longer than 10 days of the required quarantine because their symptoms were so bad. So 23% of people who had symptoms where they identified them in this study. This is a small study, and so we can't really necessarily interpret a huge amount because it wasn't systematically done to know asymptomatic infections and whatnot. So because the denominator is a little unclear, we can't really tell what percentage this is. But what this study does tell us is that long COVID can happen in people who are vaccinated, and it's probably not the rarest of all events. It might happen in a significant number of people. So this is something we're going to have to be paying attention to. Yeah, and so this is something. So it's still, I know there's a lot of research still being done on treatment for this. We have found that it's related, that people who end up with long COVID are overwhelmingly have previously been infected with one of these herpes viruses, like the Epstein-Barr virus, which causes mono, or chickenpox, or shingles, the virus that causes that. So that's herpes zoster, and some of these other viruses. Because the problem with these herpes viruses, and this group of viruses that are all under that umbrella, are that they go into our cells and then they just stay there for many years, and then they can reemerge at some point. And that's why people who got chickenpox at one point early in life, if the virus reemerges, then it can be called shingles. And it's the same virus, but it's just called something different. The problem is that if people have a reemergence of this virus, then they are way more likely to have long COVID. And we don't know exactly what's triggering people to get reemergence of any of these, to get shingles or to get reemergence of Epstein-Barr or whatnot. And we don't really have good treatments for them. But given the number of people with long COVID, this might be enough of a population. There might be enough of a demand to really reinvigorate research into this area to see if there's new therapies that can be really repurposed to focus on this. So that's good news. One other thing, I see that we're at time. One other thing I just want to spend a couple minutes talking about is this question here about colds, about the other human coronaviruses. So as I've mentioned before, there are 4 common human coronaviruses in wide circulation. Every single person gets infected to these human coronaviruses at least yearly. So there was a study that was done, a pretty small study. It only tracked 10 people, but it tracked the 10 people for years. It started in 1985 and kept on tracking the last person until 2020. So that was 26 years almost that they were tracking these people. And so because of that, they can see they were getting people's blood every single 6 months. They could see how often people were infected with these other human coronaviruses. And what they found were that people were getting infected all the time. This is just the common cold is caused by a variety of different pathogens, but the coronaviruses are very common. And so we shouldn't be crazy scared of a coronavirus just because it's a coronavirus. And so what a lot of us expect is after people have been vaccinated or been infected the first time, at some point, SARS-CoV-2 is very likely to just be the 5th human coronavirus that just causes a common cold. Most kids before the age of 2 will have been exposed to it, and they'll have immunity, and every couple of years will just get exposed again, but there's nothing to worry about. They'll either be asymptomatic or just cause the common cold. And I think that it's unlike the flu because coronaviruses don't mutate nearly as much per replication cycle. The flu mutates a lot, and that's why we have to get flu shots every single year because it's constantly mutating. The coronavirus, we see these variants that are happening, but it's actually because so many billions of people have been infected that we are seeing all these variants. Once there's more immunoprotection globally, then you're not going to see so many variants coming out. And as I've mentioned with Delta, because we might be approaching this concept of peak fitness, at some point, there's just not going to be very many new mutations that can occur that can really make it more contagious than what we're already seeing. And so as a result, we're not going to have these surges that we're seeing as much anymore. And it's probably going to be more like just a common cold that we see. And so I want people to just start seeing this like this, the common cold, each person's, this was one person. Over the course of 22 years, this person was infected 11 times by these coronaviruses, mostly by some of them. And again, this because they're just so common, virologists know the names of these things. We don't even have names. We just have codes for them. We call them NL63 and 229E and OC43 and HKU1, but really they are not things that we worry about. And so they vary seasonally a little bit differently in terms of when people are exposed and when they're infected. But this is what we think is going to be the future of SARS-CoV-2. And so the sooner we can get people vaccinated, the sooner we can get there, and this will be all over. But that's where we are.
Very, very helpful for putting it in context, Glenn. Thank you for this tremendous preparation you always do. And really, Glenn, can't say it enough. Thank you for your heroism. You know, what you're doing and sharing your vast knowledge, not just with our group, but beyond. I mean, Glenn shares it professionally. He shares it with friends and family and speaks to thousands of people. And in this day, here we are to think about how politicized our environment has become. I just want you to know how grateful we all are for your heroism, because what you're doing, you're acting so selflessly, and you're sharing the data in a way that so many can understand it. And Deborah, I see you're clapping, and I just really, we can't say it enough. Thank you. I
appreciate the sentiment, but I think the real heroes here are the ones who created the vaccines and did all that research and participated as the study participants. The nurses and physicians and medical staff who are treating all these people in the hospitals. There's so many people who are doing great work, and I think a lot of people are doing amazing work. I'm glad to help in some small way, but I mean, in terms of like people who are on the front lines of keeping people alive in the hospitals. I definitely think that they deserve the really, because of HIPAA, we're not seeing them. We're not seeing the work that they're doing, but they are struggling night and day. And I hear about these cases and I talk to nurses and physicians, but most people don't realize. And I think that's why a lot of people are not understanding how bad COVID-19 is because we don't see it on the TV. We're not aware what's going on behind the closed doors of the hospitals. And those people, they are slaving away and they are real heroes. And so anyway, if you think I'm a hero, that's who I think are the real heroes right now. But I also really appreciate all the work that you've done, Rebecca, and thank you everyone for joining in and asking questions. So I can feel like I can add some value here.
You very much are. So when are we convening again, Glenn?
Oh, that's a good question. So I'm actually going to be not available 2 Saturdays from now. So let's plan on 3 Saturdays from now.
Sundays.
Sundays rather, 3 Sundays. So what we're looking at that point is the 28th, August 29th, Sunday, August 29th. I'll put a note up on YouTube and whatnot, August 29th.
Okay, so mark your calendars, Sunday, August 29th, 7 p.m. Eastern time. In the meantime, keep sending in those great questions and to you and your loved ones, your friends and family. I hope everyone stays healthy and well and look forward to seeing you then. Thank you, Glenn.
Thanks everyone. Thanks, Rebecca. Bye-bye.